Welcome, everybody, to today's webinar. We have a wonderful topic and a wonderful speaker. I'm going to ask that we go to the slide that says Bio Cindy. Thank you. And the next slide. And now we have a special guest, Paige Hector, who is going to officially introduce our speaker, Cindy Mason. Go ahead, please, Paige.
Thanks, Merce. This is Paige Hector, and I am so honored and delighted to present Cindy Mason. I've come to know Cindy from years ago in her amazing work that she does teaching the quality indicator survey process and her background experience as a social worker and administrator. So it's my distinct pleasure. Cindy is a colleague and a mentor for me. Cindy is Vice President of Provider Services. Cindy's professional background of over 30 years of advising nursing home administrators and staff make her ideally suited to assist nursing homes in assessing and refining systems for survey success. Licensed as a clinical social worker, nursing home administrator, healthcare risk manager, and accredited as a QIS instructor, Cindy provides education and consultation to nursing home providers, translating complex regulatory requirements into concepts that can apply to managing the daily operations of nursing home life. He has worked extensively with consumers of care whose perspective is critically important in survey success. Thanks for joining us, Cindy.
Thank you so much, Paige, for the introduction, too. Before Cindy officially starts, I just want to say a few things. This is Mercedes Bernklug with the School of Social Work at the University of Iowa. Generally, we put the handouts on our website, and I apologize. We're having some problem with our server here at the University of Iowa, so the handouts have not been posted yet, but as soon as that gets taken care of, probably the next day or so, you'll find today's handouts up there. At this point, if we'll switch to the there we go, and Cindy, take it away. People on our audience, please know that at the last 10 minutes, we will delightfully answer your questions or address your concerns. So we're just going to have Cindy speak for the next 40 minutes, 45 minutes or so. Thank you, Cindy.
Okay. With you, and hopefully we can get through all this. There's a lot of information here. Hopefully it will give you some about how the indicator survey, which is currently in about half of the nation's nursing homes, surveyed under this process, and it takes us through some of the documents that also get used in that survey. However, regardless of whether you are in a QIS state or not, all this is applicable to, because the regulations are the same, regardless of whether your state gets surveyed in a QIS mode or in a traditional survey mode. This applies because it has regulatory background and support from the information we'll talk about today. So just a quick overview of what the Quality Indicator Survey is. It's a structured process to inspect nursing homes across the United States. Nursing homes annually inspected between 9 and 15 months on average, and the process is off-site survey preparation, where the surveyors gather information about the facility. They come into the facility, do a tour, and work to get themselves in order to execute the first stage of the survey. In the first stage of the survey, called preliminary investigation, the survey teams work with two groups of samples of residents who there are activities conducted with those groups, and we'll talk about those. They also conduct some tasks that routinely are done in every nursing home survey, such as doing the dining, taking a look at the medication distribution in the med pass, looking at necessary medications for residents. Based on the information that's gathered with interviews, observations, and record reviews of the census and admission groups of residents, the samples, a report is drawn, and it indicates to the surveyor which should their next step to do further investigation, which areas of care should be investigated, and which particular residents in those areas of care should be pursued in terms of determining whether their services are delivered within the standards of practice. Stage 2, which is the in-depth investigation component, the surveyors look at care areas that triggered from this previous information. They run some mandatory tasks, which are pathways to determine, to take the surveyor through a process of determining regulatory compliance. After this investigation component is done, another report is developed, and it determines a determination made as to whether the facility complies with the regulations in a variety of areas. So QIS, the QIS survey, is looking for consistency, comprehensiveness, enhanced documentation, and better use of surveyors, and it targets the surveyor to look at residents where there might in fact be an issue, not to just it's based on a sampling and then a focused, targeted, in-depth investigation. Historically, in QIS, up until until March of this year, the census sample was a group of 40 residents that were selected by the surveyor's computers. That's a random sample. Every nursing home in the United States, if you had 40 or greater residents, teams looked at 40 residents. And we'll see a slide that modifies this. Nursing homes with 100 residents now have 40 residents selected for an initial group of residents whom surveyors interview and observe and do record reviews on. Another group of residents called the admission sample is a group of residents that are more targeted for post-acute care as or functions in the survey to determine whether their discharge planning has been appropriate, to look at ulcers and a variety of other things, readmissions to the hospital. Those are 30 residents admitted over the last 6 months. The computer system and the chart audits conducting those residents, sample residents. This is from your MDS, the minimum data set. The computer pulls electronic information, calculates rates of occurrence for certain items, and we'll go through those items. So these are the three ways that when a team is in the building, they begin to have some type of identification of a resident or a care area that might need further investigation. The census sample historically has been 40 residents, and there's been some changes. If the facility has above 100 residents, they will sample 40 residents in stage 1. If the facility's census is between 60 and 100 residents during the time of the survey, they will sample 35 residents now. That's a reduction in the previous number that was standard at 40. So if residents in the facility number 33 to 60, the teams now will have 30 residents in the sample. And if the facility has anywhere between 1 and 32 residents, 9% of their total residents population will be sampled for the survey. So the census sample looks at long-stay residents. The admission sample looks at more post-acute type items and residents. The MDS is data pulled about all residents in the facility. There's a way that residents would become, or that surveyors would become acquainted with the resident, and may be to survey initiate. So if the resident wasn't selected electronically through the random sampling for a review, if a surveyor determines that there's a significant issue that needs to be evaluated, then they can add a resident or a care area to the survey. Stage 1, which is the beginning, most generally about the first 2 days of your survey. The census sample, those groups of 40 or between 4 and 30 residents, or 90% of your population if you have 1 to 32 residents. These are activities that are conducted with those residents. Resident interviews are conducted, resident observations, family and staff interviews, clinical record reviews. At the admission, 30 residents who are current or discharged residents, and there's a clinical record review conducted. The answers to these questions and interviews, for the interviews, observations, and record reviews, are entered into software, and the software tabulates the resident responses. Resident responses, the service observations, the other interview questions, the third audit questions, into rates of occurrence for specific items. So what happens during the survey is that the facility, we know, has certain functions that service a number of residents. During the survey, mandatory tasks are conducted to look at these systems in the nursing home to determine how they're functioning. We're not really going to spend time looking at that today, however. In the survey, should certain items be identified, the tasks are not always done in a survey. These are a targeted task that are only completed if there's an indication there's a problem. Be prohibition, transfer, and discharge, which often might involve your social workers, personal plan, sufficient staff, and then an extended survey if indicated. Basically, the answers to the interviews, observations, and record reviews are tabulated. The on-site interviews, observations, and record reviews conducted by the state surveyors, and the MDS data that has been electronically downloaded and tabulated into their computer software now is running a report. All the 109 items that get tabulated for that report, and they're referred to as QCLIs, or quality of care and life indicators. Based on the rates of each indicator, they're triggering, and if your facility's triggering number exceeds what the government threshold is, then the surveyors are compelled to investigate that area in stage 2 of your survey. Of course, this report and tabulation is all done electronically. So a QCLI is a resident-centered outcome and process indicator based on stage 1 preliminary investigation. That's the interviews, observations, and record reviews, in addition to your MDS. Each one of these calculations, of course, has a numerator and a denominator, and there are some relevant exclusions. On this morning or this afternoon, we're going to take a look at QCLIs related to behavior that conducted in the survey process. The threshold is the rate that MS is determined to be significant, and then if that threshold number is exceeded by the facility's rate of occurrence of these QCLIs, an in-depth investigation is warranted. So what you see on your screen now is QCLI, or a quality of care and life indicator. They're all pretty much set up the same. They identify what care it is that questions were involved with. The narrator shows what items are asked for in the stage 1 activity of the survey. So, for example, surveyors during their resident interview in stage 1, ask residents, do you choose when to get up in the morning? Do you choose when to go to bed at night? And anytime a resident says no, there's one more in the numerator. Eventually, there's a calculation, and that percentage rate of occurrence is determined for your organization. So you have a facility that exceeds 15% for facilities that have a number of residents in their facility during the survey, then you would trigger the threshold and you would get investigated for the care area of choices. Now, the numbers, small and not small, are significant because during the survey, the thresholds are grouped in 2 groups. Small, meaning in the census sample, those residents are selected when the survey teams first come in. If there's 35 or fewer residents in the census sample, they use one list, and we'll look at that. They use the small number. So a facility with 35 or less residents during the survey would calculate it against this number, and a facility that has 36 or more in the census sample would be calculated against the not small threshold. So what this is just basically, if you have over 35 residents in the facility at the time of your survey, they would always standardly use the not small sample to calculate your rate. Family interview, there's no such adjustment for that. In the admission sample, those usually 30 residents who were admitted over the last 6 months, if your facility had 9 or fewer residents in that sample, meaning you'd submitted less than 10 people in the last 6 months, then they would use the threshold number for small and likewise for not small. Anyone has greater than 10 residents in that category during your survey. So QCLIs are very important components of the QIS survey, but they're also very significant components in identifying in a quality assurance way, identifying the potential that there may be issues in care delivery, that the outcomes may not be what the facility would intend, and outcomes may not meet the regulatory standard. The facility enters into an agreement with CMS when they federal government dollars for care that indicates that they will comply with all the conditions of participation, that they will comply with the regulations, they will provide appropriate services for residents. So this is a survey mechanism to identify those. This process also is very usable in helping to identify internally in nursing homes the opportunity to look at an area to determine whether you are delivering the care at the level of quality that your organization would wish to achieve, and that is required from a regulatory standpoint. So the list of all of the items that are converted to QCLIs, and it's called QCLI Dictionary. And you see a list of those items here. It tells you what triggered dangerous device use and what the thresholds are. So it's an index of every one of the items. So we're only going to look at behavior and emotional status. So the number of care areas, what happens if you exceed the threshold is you trigger the care area. It may be social work, it may be dignity, it may be choices, it may be pressure ulcers. Computer then, after it tabulates the fact that you've exceeded the threshold, selects residents for specific targeted review. However, in addition to these samples, the survey teams look at one resident who receives dialysis, hospice, PASS-RM data as a preliminary investigation into these specialty areas of care. So during stage 2, the surveyor's computer selects residents for sampling, generally 3 residents in every area. That the computer determine which one of the stage 2 investigation processes would be significant for the surveyor to use, and their software automatically presents that pathway for them. Today, we're going to look at something called a specific critical element pathway in our case scenario. And for behavior and emotional status, there is a specific critical pathway that has been developed that walks the surveyor through the regulations in that area, as well as associated regulations that would be significant in providing the appropriate services to residents with behavioral and emotional conditions. So we will take an opportunity to look at a pathway today. The pathway has the same core component questions or the same process. It can be a problem assessment and problem-solving process. It requires a comprehensive assessment. So workers in long-term care are required via the MDS and or social histories and other mechanisms to identify and assess the needs of residents to assist them in achieving their highest practicable mental and psychosocial well-being. We are then required to have care planning. It doesn't matter whether you're looking at choices or dignity or pain. These are all the processes that we must go through to identify issues for the resident, and then as a process of identification, develop a plan of care and treatment that's appropriate to meet those assessed needs. Care is required. We will talk about care planning for a scenario here this afternoon. Implementation of the plan of care by qualified persons. Not only is it important to get an accurate assessment and develop an accurate care plan, but then the plan of care has to be executed. And in this survey process, the surveyors do look and determine whether the care plan that was developed by the facility is actually implemented. Does the care plan need a revision, or is it appropriate currently? And do we provide the necessary care and services for that particular clinical or area? There's also in each one of these pathways insight to the surveyors, but facility in terms of looking again at quality, using this survey process to be proactive in problem identification. In the pathways, and we'll look at this, they look at associated structure, process, and outcome. In other words, if we identify something in one area, does it lead us down the pathway to other areas that may be non-compliant? Any of the QIS forms, you can go to Providigm and you would be able to link to those forms. Under resources, and if you hit this link, it will take you straight to the forms if you're interested in looking at QIS forms, which include the copy of the behavior pathway that we're going to look at today. Behavior and emotional status. Let's start by what is required by federal government. What is the regulation with regard to the behavior and emotional status and care of residents in that area? You must have a comprehensive assessment. And comprehensive assessment to ensure that a resident who displays mental or psychosocial adjustment difficulties receives appropriate treatment and services to correct that assessed problem. So the intent of this regulation that resident receives care and services to assist them in obtaining and maintaining the highest practicable mental and psychosocial functioning. Define mental and social and emotional status this way from a regulatory standpoint, and this is the perspective of the surveyor, that mental and psychosocial adjustment difficulties refer to problems in adapting to changes in life circumstances. And certainly admission to a nursing home represents a significant adaptation in and the need for adaptation and a change in life circumstances. The former, the mental, from internal thought processes. What is that person thinking? How distressed are they? Are they worrying that they'll lose their home, they'll lose their pet, they'll lose their life? Matter, the psychosocial, on external manifestations of these thought patterns. So you have someone who's thinking about something, and then, of course, as they act and as they interact with other people, they can see the external manifestation of their thought processes. The things that go into the MDS assessment. Psychosocial adjustment difficulties are characterized by an overwhelming sense of loss. Of course, when you go to a nursing home, sometimes you've lost your family and friends, or you're older and you've lost people in life. The ability to continue to pursue activities is certainly disrupted by displacement from your home and your home environment, and hobbies, and of one's possessions. So we're looking at people who have a sense of loss, who have a sense of hopelessness, maybe helplessness. So the sense of loss that we're talking about for adjustment is global, uncontrollable, supported by thinking of hopeless and helplessness, but maybe all of their significant meaning ceases to exist. Many people are cut off significantly from their roles, from their families, and cannot engage into what they consider their normal life after placement. But a resident with a mental adjustment disorder will display some type of anxious mood or behavioral symptoms such as aggression. DSM-4 indicates that adjustment disorders develop within 3 months of a stressor, and that's significant. Sometimes people have this prior to coming to the nursing home. Everyone has a different baseline, but we're specifically talking about adjustments, and evidenced by significant functional impairment. So it's also just that resident's response. It changes the way that resident is able to function, and so there is a significant functional impairment. Bereavement is not considered in these regulations to be in this category as an adjustment disorder, but as a bereavement issue. This assessment does not reveal a mental or psychosocial adjustment difficulty, display that pattern of decreased social interaction, anger, withdrawal, depressive behaviors, and that's a clinical condition that is unavoidable for the resident. So when we're looking for this during the survey environment, when the report from a regulatory environment, looking at people who may be displaying these things and who might not have had an assessment. But the goal is that the resident matches their assessment in the behavioral and psychosocial area. So residents who are sampled, so this gets triggered, and they focus on a resident to look at in the second part of their survey. So residents who got sampled, whose assessment didn't reveal an adjustment problem. So MDS shows no problems, no other assessments show any kind of problems, but they see it, the display of this decreased interaction or depressive behaviors as appropriate, that this was avoidable. If it was avoidable because of some type of lapse of assessment or service provision on the part of the facility, this may be an issue. We're going to look further and put this in more of a perspective from a case scenario. How would behavioral status trigger in stage 1? So what would trigger that? And we're going to answer these questions coming up. When it does trigger, what would the survey process look like in terms of investigating this if it would trigger? Because just because something triggers for an investigation does not mean that it is inappropriate care, that it's in non-compliance with the regulation, or it's poor quality. It means that there was something significant enough that this area should be investigated or evaluated to determine whether there's a failure in the system of service delivery in the facility, that the resident's getting the appropriate care and services that they need to achieve an outcome maximal for them. So the QCLI Dictionary, we saw the long list earlier. There is a section that has indicators for behavior and emotional status. And there are the three items the dictionary lists that specifically relate to the care area of behavior and emotional status. These indicators are for your MDS, and they talk about increased physical abuse, increased rejection of care. So specifically look at this or indicator that could trigger at a certain rate and require the surveyor to investigate it. But also, if used as a quality assurance process, should also indicate to the facility that it's an area that may need to be investigated so you can assure that your processes are in place and that the resident receives the appropriate care and services. So this is the care area of behavior and emotional status. Particular QCLI or quality of care and life indicator is pulled from information the staff code in the MDS, mission, and the 90-day MDS. So it looks at change over time between your mission MDS and your 90-day MDS, the area of physical abuse. As you know, there's a question on the MDS that talks about behavioral symptoms and the presence and frequency of certain behavioral symptoms. That's the section that this information is pulled from. So the resident, in order to be in this calculation, and every MDS that's submitted over the previous 6 months is included to determine whether you've exceeded the government threshold. And that's where the information comes into the survey through your MDS process. The MDS is downloaded prior to the survey, your MDS report, and then the surveyor has a report of the findings from your MDS that's electronically provided. So with increase in physically abusive behaviors, first the resident has to have a 90-day MDS and an admission MDS. So if the resident hasn't reached 90 days, they will not be in this mix because they would not have had the required assessments to do this calculation. Physical abusive behavior sits on the MDS is one more levels less than on the 90-day. So in other words, if your MDS was a 1 and then your 90-day MDS is coded as a 2 in behavior, it shows that there's an increase in the types of behavior or the frequency of this type of behavior. And those would be the MDSs that would be used or specifically gathered for the numerator of this calculation. The denominator takes residents with an admission 90-day MDS that has answers to the physical abuse question, and that's the denominator. So all residents who had that admission 90-day with that question answer would be the denominator. So this is the value that could have gone into the numerator, and this is the group that actually did go into the numerator because their MDS had that required change of 1 or more levels. So after your MDS data is run, better than 4% of MDS is basically calculated out to this, or the rate of occurrence of this item is greater than 4%, then the survey team would investigate the care area of behavior and emotional status in stage 2 of your survey. But it has to do with increase in physical abuse between the admission and the 90-day MDS. As you see, there are some exclusions here, and that means these residents will not be put in the calculation, that they are excluded from the calculation because of a certain reason, and in type it's because they already were having daily behavioral problems. other potential item that could trigger in your QS survey that makes surveyors to look at behavior and emotional status of your residents. The coding in objection of care section of your MDS under behaviors. This would talk with an increase for rejection of care. The rejection of care on the MDS is one or more levels less than on the 90-day. Again, change over time. Lower, and then on 90-day, the coding is higher. That puts you in the numerator, and if greater than 35% of your assessments meet these criteria, then you could trigger a stage 2 investigation in behavior and emotional status. And last but not least, this is the third way behavior and emotional status might trigger for your survey and require the surveyor to do more in-depth investigation, is the fact your MDS, again, it's rejection of care, rests with the previous and most recent MDS. So the other one was admission and 90-day. This is previous and most recent, so it may capture a different group of residents. It looks at rejection of care, one or more levels less on the most recent than the previous MDS. So it's very significant to recognize that if you're documenting on residents and you're completing their MDSs, that if you see a change, if there is an increase in symptoms or the frequency of the resident symptoms, and you're coding your MDS a higher number than it previously was in these behavioral areas, could result in an opportunity to have a survey focus if it meets these threshold rates. So it would behoove you to or that you had an assessment in the record that reflects why you think these are being changed, and certainly to visit the plan of care to determine whether it's still appropriate for that resident. So talk about a case scenario. We're going to apply this. It couldn't be loaded to the website, and we apologize for that. But we've got Mercedes scanned this in before the presentation, so we do have it available for the presentation purposes. This is a case scenario of Mrs. Jones. And seeing on your screen is the document, the stage 2 document that would be completed during the survey in the event that this area triggered. So let's look at this document because it's valuable to you on several fronts. First off, you would know that the surveyor would complete this when they came during the survey. But more importantly, it assists you in thinking through what services, how residents are being cared for, looking at your own practice, looking at quality to determine whether you have thoroughly completed the requirements for a resident, to assess them, to make sure that they get the appropriate care and services that are needed. So in general, this item, this document would be used, this pathway will be used when a resident has physical or verbally abusive behaviors, socially inappropriate behaviors, psychosocial adjustment difficulties, symptoms of depression or delirium. And the surveyor has one of these pathways. It gives them a procedure to follow, and generally they're pretty much the same. First, the assessment. So always important that if you use this method for quality assurance, that if you pick a resident to look at, you start with their assessment. Then based on that assessment, look at the plan of care that was developed. Those two things obviously should connect. And then orders to identify facility interventions and observations. So the surveyor looks at the care plan, they look at the record, they look at the assessment, and then they determine what types of things the facility has said that they're going to be providing for this resident, and implementation of the plan of care. The surveyor can't just unilaterally do that. They have to corroborate their observations by interviews and record reviews, talking with the staff, looking what's documented in the records to corroborate their findings. So this first page of the document, the left-hand column tells the surveyor what types of things they should be thinking about and looking for in this particular area of care. Because it's triggered, they're conducting an investigation. This kind of takes them through the investigative process. So surveyors are immediately asked to observe whether staff consistently implement a plan of care over time across various shifts. If we've had to develop behavioral or emotional support plan of care, then is that care being implemented? Is the staff doing what is prescribed on the plan of care and treatment? Expected to assess the resident for behavioral and mental status. We know that from the date of admission. The observations, survey notes any deviations or negative outcomes for the plan of care or the services for the resident. The surveyor is instructed to look at from resident interactions. How do the staff respond to residents who are exhibiting behavioral problems? They apply the plan of care, and how is that observed? How does that interaction occur? The quality of the resident's life, ensuring the safety of others. It mentions specifically are employed from one staff to another across shifts. So those are types of general things that the surveyor would be looking at during that. On the right-hand side, presentation that's a type of a case study scenario. When you get your posting on the web, there's a case scenario. This is the resulting document of the case scenario, but we're going to just use this document for today. The document says this critical element, which is like this critical element pathway, this document, is being completed because it triggered from admission to the 90-day MDS, indicated that the resident had an increase in physical behaviors, which was pacing and pushing, on the 90-day assessment. So that resident had a higher 90-day coding on behavior they did on the admission MDS. So the residents first got calculated, they got pulled in through the MDS sample, and the MDS sample identified this care area. So that meant is the facility had to have exceeded the threshold percentage. And for this particular item, it is 4%. So greater than 4% of your MDSs showed this item to be the case, that were from admission to 90-day MDSs, why this investigation would occur. The resident had to have observations. The surveyors always do observations. In this observation, the surveyor saw the resident in the dining room with the food untouched. Basically, the resident's head was bobbing up and down toward the food. With the nursing assistants, remember, it said corroborate. It was interview and record review. This is a corroboration with the staff of what the surveyor is seeing. The interview with the nursing assistant basically said she usually ate very well, but really all she could do is to keep her awake during breakfast. She said be very drowsy. She said the resident said she's always very sleepy. The nursing assistant tries to arouse her, but she pushes the nursing assistant away. And the nursing assistant advises the surveyor that she had, in fact, reported this to the nurse. So the surveyor does multiple observations during the survey. And this resident was observed on several occasions, both at 9:30 and 11:30 a.m. And the music is on and the lights were on in the room. At 12:30, the surveyor observes the daughter come in, and the daughter wakes her mother up. So this resident had been sleeping for a number of hours in the morning. And the staff is reporting drowsiness and inability to execute some of her ALs. Drowsiness is also significant because obviously if the resident can't eat because they're too drowsy, there could be some other clinical problems that crop up later on. So the daughter came in, and the surveyor interviews the daughter. Again, corroboration by interview, talking with the patient's family. Daughter said that she visits every day for lunch. She said her mother was always sleeping. Her mother told her she didn't know what was wrong with her. She slept away the day. The resident was observed at 8:10 in the morning. The nursing assistant would walk her down the hallway. She kept pushing the nursing assistant away. And the nursing assistant reports, I'm sure after being asked about how does a resident generally function, that some days she's lost by herself and she does really well, but other days she's really groggy and she's sleepy, and she's very concerned that she will another fall from being drowsy. So the implication here is that the resident, in addition to not being able to eat when she's drowsy, also may have a risk for falls. Second shift nursing staff gets interviewed. They say she's a little confused at times, but they also say she just won't stay in her room at night and tries to go to get her back in bed. She keeps coming into the hallway. The resident paces in the hallways, and they keep taking her back. So it becomes a round and round. The resident comes out into the hallway. The staff don't want in the hallway. The staff take her back in the room, and this happens round and round again. The then gives her something to go to sleep. And the nursing assistant isn't aware of any interventions, didn't know where the care plans were kept, and didn't know that the radio DVD player were interventions in the plan of care. But she saw them in the room, but she didn't know that those might help to resolve some of her behaviors. So you can see the scenario building here where the resident's drowsy, there's issues with the staff trying to give her care, and the staff aren't familiar with the plan of care. Then the surveyor on the left-hand side is instructed to, of course, interview the resident's family, which we see the beginning of already, and to determine, does the family have any insight into why these items might occur? Well, that would certainly be a typical social work cross-note or assessment. Why is there anything the families can share with us about what might trigger behavior? Why is this a change in behavior, and address those issues with the family? Are they aware of any types of management programs, medications, treatments, behavioral interventions for that resident? And as a family, if they've refused, as for example, psychiatric services, or were they advised as to the risk or complications that might result as an exercise of right to refuse treatment? So that's what the surveyor is probing, and these notes address this issue. I interviewed the daughter, who said that the resident was happy, sometimes a little confused. She was basically harmless. She wandered around the unit, that she was the person to be notified in the change of her mother's condition, that she attends all the care plan conferences, that basically she had heard the care plan meeting interventions for confusion, wandering, and falls, and the nurse discussed her mother's medication and included Ativan and Zyprexa, but was aware that they had given her the Ativan. So Ativan is, medication for anxiety. Daughter discussed the staff, the classical music, old movies that she provided in the room with DVD, leaving the lights on, seemed to soothe her mother. And during the care plan meeting, assured the daughter that these were on the plan of care and they would be provided prior to any use of medication. But mentioned the staff nurse that she had noticed when she comes to visit, she was tired, she can't keep her eyes open, and the nurse said she would call the physician about her concerns. So obviously the daughter is also seeing this change in condition. She's saying that, she wasn't supposed to be given Ativan, these behavioral issues, and she had not been notified that they had been giving the Ativan, or that was a severe an issue. So all in addition to talking to the resident and families, staff are interviewed about their knowledge about the care and services the resident should get. So knowledge of what interventions should be made and how this is communicated between the staff, the process to read behavior and psychosocial symptoms, and the role played by various disciplines, who's going to do what in the provision of care and services. And if nursing assistants know what, when, and whom to report a change in behavioral or emotional status. I see the surveyor answers to this particular scenario that for the resident at 1 o'clock, she said that the resident was pleasant and confused, but she didn't pace on her shift. She said she was given Zyprexa and Ativan PRM, but she never had to give the Ativan to the resident. So she never assessed it from a nursing perspective, the need to provide that level of chemical intervention on the part of the resident, because she didn't see the behaviors. 4:30, the second shift nurse came on and said that doesn't always pace in the hallways, her shift, and that the staff put her back in the room. She wouldn't stay there to go to sleep, and she verified that the physician was Ativan, and the nurse verified that she had administered that Ativan on 18 times on her shift in the past 30 days, and with 12 minutes toward the end of November and 6 at the beginning of December. So, in other words, the perspective on this resident is quite different. The day shift says they don't pace, they're fine, they just wander around a little bit. The second staff see this pacing, and the fact that it appears that they have identified the problem being that the resident won't stay in their room. And as we know, that is not necessarily a reason to give someone a medication of this degree, because coming out of their room, that the resident has a right to come out of their room, and they should not be chemically restrained involuntarily for convenience. So this wasn't aware of any interventions were on the care plan, and she didn't think about looking at that, like the lights on and the DVDs and the old movies. She said that at the same time, the resident keeps getting up out of bed. She sleeps like a log when they give her the medication. We know there's a significant movement nationally to address the use of unnecessary medications, including antibiotics, antidepressants, antibiotics, and the like in long-term care, specifically those that are psychoactive medications, or anxieties, hypnotics, and the psychotropic drugs. So this circumstance also would be one that would be during the survey, because there's mechanisms built in the survey process to identify residents who may have medications that are inappropriate as well. So this resident possibly could have been picked up in a way to look at this area. So DON was interviewed, again, correlation about what the surveyor is seeing. She verified that the nurses and nursing assistants should have been aware of the behavioral interventions to the utilization of the medication, the LVM, that she verified that the resident had behaviors and that were and the nurse should have notified the physician if those behaviors were that severe. And also verified that the consultant pharmacist came in. They reviewed this drug regime and indicated that it was something that needed to be looked at, and they should be evaluated for the use of the medication. And she did not have time to read the report and was unable to have the intervention because she hadn't read the report yet. So the point to be made in this scenario is the fact that this has been going on for a while, and there have been multiple systems failures, even check and balance of the consultant pharmacist. So I think from a social work perspective, we are certainly the eyes and ears for some of our residents and could bring some of these things to attention of the care plan team when taking a behavioral approach as an immediate use of medication to treat behavioral symptoms. And from a regulatory standpoint, all of these 5 elements of care we talked about earlier, this is the assessment. And the surveyor has to establish whether the facility accurately assessed this resident to determine what care and services they need. So I tell them to look at all the orders and the documents in the chart and look at the behaviors that the resident exhibited. In this scenario, the surveyor, the admission MDS indicated there was behavioral symptoms accordingly, indicated the increase. No evidence of pharmacological interventions attempted prior to Ativan. The nurse's notes revealed that they were documenting the pacing that we discussed earlier. And the MDS nurse was interviewed, and she said that she got this from the record, that the resident did have an increase in behaviors on her quarterly, and she thought the staff would know where the care plans were, but she didn't know how nursing staff made each other aware of that. So communication and system breakdown between the MDS staff and the care planning staff and the actual floor staff. So several opportunities for quality improvement identified just through looking at the process breakdowns that are occurring that are resulting in the failure of this resident to have behavioral interventions applied. Is good from a quality assurance performance improvements process because it's really about the process. From a regulatory standpoint, some questions have to be answered. And the first one is, was this thing that the surveyors are looking at a significant change in condition? And if there's a big changeover and it's not reflected in the chart, then maybe this facility missed a significant change. But in the event that there was no significant change, the surveyor has to establish if the condition risks were present at the time of the assessment, and did it address those risks and underlying causes in the assessment process. In this scenario, the answer is yes. Actually did have an MDS assessment. It showed that change over time. So assessment is not where the regulatory breakdown would come in on this particular scenario, because they in fact did get the assessment. The surveyor has to document care planning and determine whether the care plan was developed that meets the risks and standards, needs, and is measurable objectives in a timetable. This documentation on the right supports basically the fact that they did have a plan of care. It showed that the resident had some confusion, pushing pacing to use the DVDs, give her hot chocolate, magazines, books, cat into the room, and then if non-pharmacological interventions were not effective to administer. It was, in fact, a plan of care. It was a very extensive plan of care to address this issue. Surveyor in this scenario said yes to the question that they have to answer every time they work one of these pathways. That, in fact, the facility did develop a plan of care with interventions and goals that will treat the residents' behavior and psychosocial mental symptoms that would assist in improving those symptoms. The facility both had the assessment process in place and the care plan development process in place. Breakdown comes in this scenario, and very frequently this is where the breakdown comes in many actual surveys. Then implementation of the plan of care. And so the plan of care was developed, but obviously the staff have not got a system down to communicate who's supposed to be doing it on the plan of care, and the frontline staff don't have don't know what the care plans are or what's on the plan of care. So the development of the plan of care was beautiful, but the execution was inadequate. See here is the facility. Did the facility provide a range for services to be provided by a qualified person in accordance with the written plan of care? And the answer here, of course, is no. That when I interviewed the staff, they didn't know about it. They said they did not provide any kind of non-pharmacological interventions prior to using the medication intervention. DON verified that as well. Then we have to also look to determine whether there was a needed care plan revision. In this particular scenario, there's not necessarily a provision, a lack or need to change the care plan. The care was adequate, it just wasn't implemented. So did we basically meet that standard? They said yes, that there was actually a revision needed. And then there's several questions at the end of this document that relate to the provision of psychosocial care. And so the surveyor and you, if you're using this for quality, want to determine whether you assess and recognize the behavioral factors, psychosocial factors, and whether there was any kind of avoidable problems. So the first question is F319, and we looked at that on the regulatory slide. And the regulation said that the facility has to provide appropriate treatment. First, we have to assess and make sure our problems are assessed, and then provide the appropriate treatment for our psychosocially, emotional, behavioral issues. In this case, you'll see the answer is NA. And at first, you may think, that doesn't seem right. But basically, this resident didn't display a psychosocial or adjustment difficulty. It wasn't something within 3 months of a stressor. She was having an angry, withdrawn, hostile type of reaction to care. What did happen was that the social worker was interviewed. She verified the resident was pleasant. She'd done very well, that she paced at time, that there was interventions to reduce behavior, that the doctor told them what to do, and it seemed to be working for them because it worked for the daughter at home. So, in fact, there was no assessment of there being a problem that the resident was having related to the adjustment to the facility. Now, the second component to this F319 tag, and then F320, based interview, observation, and record review. A resident whose assessment did not reveal mental or psychosocial problems, did display any. She did psychosocial problem, but she also didn't have a decreased interaction or more depressive behaviors or anger. So the answer here is yes, that that we met the standard. On this particular standard, which is another question, based on observation or interviews and record reviews, did the facility provide the necessary care and services to attain or maintain the highest practicable in accordance with the assessment and the plan of care? Of course, the answer here is no. They did provide the care and services that was written in the plan of care. They didn't do the things that the facility indicated themselves and assessed as necessary for the resident. So the facility would take a citation under F309, which is that relates to the provision of care and services to the resident. So the resident didn't receive appropriate care regarding her behaviors, very specific interventions. The staff were not aware of the interventions. They didn't implement them. They used medications prior to implementing the non-pharmacological activities on the plan of care, and they failed to follow the pharmacy report that indicated this should be reviewed, the use of the Ativan so frequently. So the facility would have taken 2 deficiencies just from this one investigation. One would have been doing the implementation of the care, and another, that failed to provide the necessary care and services that the resident needed to achieve their highest physical and psychosocial well-being. And last but not least is the section on the back side of all these that talks about independent and associated structure, process, and outcome. In words, a fancy way of saying, are there any other areas that we should look at related to the case that we just reviewed for behavioral and emotional status? The notification of change is a requirement in the regulations. It says that the family has to be notified of a significant change in treatment, which would be the use of the Ativan frequently. The family was unaware of that. Dignity. Is very undignified to not be able to eat and to put on your plate because you're potentially over-medicated, because people are trying to potentially control your behavior. The falls that the resident experienced related to the use of the medication to treat her behavior, and unnecessary medication use, just in general, looking at the use of that drug on a PRN basis without the appropriate standard of care being met. So Sarah looks at all these items, sees if there's anything related. The other issue that could come up in this particular case might be abuse, and that would probably come through the unnecessary medication doorway, because once that was determined, and if it was determined that the staff used the medication as a chemical restraint to keep the resident in her room, then it could open up an abuse investigation in terms of inappropriate, use of behavior controls to try unnecessary restraint, chemical restraint on the part of the resident. That's essentially where we're at on all these particular documents. It's a multifaceted survey process, and this is one way that they might look at behavior in event and emotional status of your residents in the event that it would trigger in the survey process. Sadie, if you have any questions, I'll be glad to respond to those.
Are there any questions? If you are online and want to type in the chat or in the Q&A, we can do that. Or if you called in, you can go ahead and put your hand up, and I will try to make your phone muted. So, questions or any comments? I don't see questions at this.
I have some question that just came up. Should I go ahead?
Sure.
Conley has asked, how can we get the QIS forms? How can a non-QIS state use the forms? Non-QIS state, I'm going to go back to the web page, can use the by printing off the CMS website and integrate these into your practice on a day-to-day basis. You go to QTSO.com and hit the link that says QIS and then forms, and when you hit that, it will drop down a list of all these forms, and this particular one, the behavior and emotional status, can be accessed from that site as well. So these are available in the on the website. And also the next question was, how will the forms help you in care planning? Well, one of the things that happens in this process is you have to evaluate whether you've met the standard of care. So when you go back to the pathway, it talks about the issue of care planning. And it takes a surveyor and also you the process to determine what might be an appropriate plan of care for this particular item or care area, this time behavior emotional status. So determine whether the facility developed a plan of care. So if you take out one of your plans of care related to behavior and emotional status, whether you look at your plan of care, ask yourself this question: is the plan of care that you developed consistent with the resident's specific conditions, the things that you identified in your assessment, the things that you identified of that resident that need to be addressed, the risk of that? Some certain treatments and refusal of treatment have risk. Did you address that in the plan of care? The need of the resident, does the resident need psychological services? Do they need psychiatric follow-up? Do they need some type of support? Do they need more activity? what are in accordance with their preferences and the standard practice. Are your objectives measurable? That's a tough one. Sometimes it's hard to look at those measurable objectives. And is there a timetable accomplishment of those? Is it a week? Is it a month? Is it 3 months? What timetable do you add to your care plan? What time frame are you going to go back and reassess that resident? And that's another significant part, is that care planning requires reassessment. Every quarter we reassess the resident from an MDS perspective. There may be other things that you need to assess that are not picked up through the MDS. But during that core assessment, your risk should certainly, at a minimum, reflect any changes you saw to the MDS. What over time, what kind of services? Is the plan of care still effective? Does it need to be revised? Or is we're doing addressing the problem, or is it making it worse? So you see in this area different ways to evaluate your care plan, determine if the emotional support that's necessary, and identify the intervention. So take this section and compare it to your plan of care and see how you think you hold up.
There's a question that Paige sent to all panelists. Please elaborate on the implementation of qualified persons in your example. That the aides were not informed of the interventions is why they were determined not qualified. Is that correct?
No, what I would say on that is that it depends on the intervention. If that staff person professionally licensed to perform that activity, certainly you can't perform something you don't know about, and I agree with that. They're qualified, like, for example, the aide would be qualified to go in and put on a movie for a resident. The aide would not be able to go in and give the medication. So qualified personnel would indicate that that person who is assigned those functions in the care plan, in the planning process, actually has the licensure and the clinical status and the knowledge and the training to execute those functions.
Okay.
And if someone's not, if some know about the interventions, then it's all for naught.
It sounds from what you described today that this really does have the potential to improve care, to enhance care,
to
make sure that the dots are connected, but it also raises the expectations, it seems, on behalf of staff. Would that be a fair statement? I
think that that's a pretty fair statement. I think that the expectations have always been the same. Regulations are the regulations. The adherence to the regulations has always been required. But this process, this is a survey process that's come up with the last 5 years. This survey process itself lends staff the tools to look at their practice in a very critical way, which using the regulatory standard to see if they've achieved that practice. And so historically, the surveyors nor the providers had access to a very structured process that every time someone gets looked at for behavior and emotional status, we're going through the same process to evaluate care and determine whether it meets the standard of practice. So this process very much can be used as quality assurance. This can be used as a core component. The other thing that's very important is nursing home social workers coming up is that we know that CMS is going to do something they call quality assurance performance improvement. And in the coming year or whenever the regulation comes out, it will require that certain care areas be monitored, and quality of life and quality of care will be required to be monitored. Social workers may need to determine what area of practice, how they're going to monitor for possible issues, and this is one way to do that.
Okay. So that's a very good point that you made, that the expectations have remained the same. But in one respect, this kind of levels the playing field because previous research has found that the survey process was kind of enacted very differently in different parts of the country and even within the same state. So this seems to standardize to a certain extent what surveyors will be looking for. Also, then it lets the staff know ahead of time how, kind of what the expectations are on a step-by-step basis for providing the kind of care they're getting paid for.
That's absolutely true. And absolutely, we call it an open book test. Paige will test that. I mean, we've had discussion. We have tools now available to us, if we're aware of them, that can help us critically look at how we provide services. And some workers don't go into this business not wanting to do a fabulous job. Every worker I've worked with has really worked very hard and very dedicated, and sometimes aren't given the tools necessary. But this is one of the tools that can help them look proactively at their own practice.
Excellent. Any questions or any other comments that people would like to type in or raise their cyber hand for? Okay. Another thing, Cindy, that comes to mind is not all nursing homes have people in their social services department who are licensed above.
Yes.
You know, so,
and they get your state licensure on that. So like Jim said, there's one level of licensure, LCSW. But nursing social workers don't have to have any credentials at all. They waive them.
Well,
so you don't have to have any education. I mean, no, you don't have to meet the NHSW standard. So
this process that you've talked about today becomes more widespread. Then the facility, if they don't have a qualified social worker, is going to have to still meet those standards, but be able to document that done so through another agency or consultant or something like that.
No, they don't require consultants. I know this just sounds unbelievable, but there used to be a consultant requirement in the pre-OBRA days, which was like the late 80s, and because I did that practice. Then when OBRA 87 came out in about early 90s, late 80s, they eliminated the short consulting requirement. So it says you either have to, if you have a facility that has 120 beds, then you have to have somebody who has a degree in social work, psychology, sociology, and 1 year supervised experience. And if you have 120 beds or down, there's two ways that people look at this. They either say you have to be on a full-time basis if it's over 120, but some say a qualified person over 120. But what I see it applied as, if you have 120 less beds in your nursing home, if that person comes off, they don't have to have any special degree. The NSWs realized that, but they weren't effective in getting that moved. So
this process here, though, will still hold that nursing home responsible for identifying and care planning and providing that care, whether or not they have somebody on staff who can do that.
Absolutely correct. It's geared toward meeting the needs of the residents. And if the residents' needs aren't met and that's identified, then there's a problem.
Okay. This is so helpful. Thank you so much for making the time and having this concrete example and then showing people the forms and giving people the resources to get more information if they'd like. And we'll post this on our website. Usually I put the recording, and this is being recorded, up within a couple hours, but frankly for today I don't know how long it will take for the recording to get up because of our server issues. But with that, I'd like to thank Cindy very much for sharing this information with us. And I like the way you said it. It's like an open book test. And so let's crack open that book and let's be getting the residents the absolutely best care that we can. Thanks for your time and your attention, and I'll be posting our next webinar when it's confirmed.
Okay.